Okay, so this is part 2 of the lecture. This is going to be a module that covers thyroid cancer. So starting this out with a this versus that case, we've got two grayscale images through the thyroid. The red image is a solid nodule. Looks pretty large. Can't tell for sure without calipers on it, but you'd bet that it's probably big enough to be biopsied. The one in the orange is primarily cystic, and it's demonstrating this comet tail artifact, which is a type of reverberation artifact, and we will talk about that more in the ultrasound physics lecture. So let's compare and contrast sort of general features of things that get a needle and things you have to let go. The first one is size. So things that are big are bad. Smaller things tend to be not bad. The second one is whether or not it's solid or whether or not it's cystic. Solid things are bad. Cystic things are not bad. And the last thing is the presence of microcalcifications versus the presence of a comet tail artifact. Now, out of these, if you were given a question, this would be a good question. Which of the following characteristics is the most worrisome? So the consensus article on thyroid nodule biopsy says that you should biopsy mixed solid and cystic nodules around 2 centimeters, solid nodules at 1.5, and nodules with microcalcifications at 1 centimeter. In other words, microcalcifications trump size, and being solid trumps size also. So the most significant thing is the microcalcifications. The second most significant thing is whether or not it's solid, and the third most significant thing is the size. So size matters, but third most. So looking back at these two nodules, the one on the red would get a needle, and the one on the orange would have to let that go. See, here's a next case, another grayscale thyroid image, and with a zoom up you can see that this one has microcalcifications. And even though it's not very big, it's going to get a biopsy because, remember, that is the number one criteria. Microcalcifications, number one. Solid versus cystic, solid number 2, size number 3. So let's do a few more nukes cases, because this is a big part of working up thyroids. And let's talk about hot nodules versus cold nodules. Most thyroid nodules are actually cold, and therefore most are benign. Colloid, cyst, etc. Those things are going to be cold. They don't have functional thyroid tissue. They're not going to take up the tracer. In fact, most cold nodules in a multinodular goiter are even less likely to be cancer compared to a single cold nodule. Having said all of that, cold nodules are much more likely to be cancer when compared to a functional or a warm nodule. So you can think about something that's losing its functionality, something that's changing, is going to turn cold. So a cancer would do that. A cancer would be cold. C for C, cancer cold. But also know that, as I mentioned before, biopsying benign thyroid nodules funds most body divisions. So there's tons of other reasons to have a cold nodule, and most cold nodules are benign, but you're still stuck with having to work them up. Now, this next case of this versus that is this thing that I mentioned before in Module 1 called a discordant nodule. So what the hell does that mean? Basically, as I mentioned before, you can use TEC or you can use an iodine agent to image the thyroid. And they work similar, but there's a difference where both agents, both TEC and iodine, are going to go into the cell. They're going to diffuse through into the cell, just like normal iodine would do. But only the iodine agents are going to go through the process of organification. So they're going to get stuck inside. So you can have a situation where you have a hot nodule on tech that then becomes cold on 123. In other words, some cancers maintain their ability to trap but lose their ability to organify. So you can have a hot nodule on tech, but it shouldn't be considered benign until you can show that it's also hot on iodine 123 or 131. So in other words, a hot nodule on Tech 99 does not mean that it's truly a cold nodule. It can be discordant if they don't agree. That's a high-yield topic because it emphasizes this fact that technetium is not organified, and for some reason, academic radiologists are obsessed with that. So now let's talk about the crab cancer. So there's 4 main types of cancer that occur in the thyroid. And I'm just going to list like 1 or 2 facts about each one that are worth knowing. So papillary is popular. It's the most common subtype. It does well with surgery. It does well with radioablation with 131. Follicular, the thing to know about that one is that it tends to metastasize hematogenously as opposed to through lymphatics. Medullary is got a lot of trivia about it. The main things to know is that it's associated with the MEN syndromes. It's neuroendocrine in origin, so occasionally it can take up MIBG or octreotide. They tend to be cold on a thyroid scan, and they don't typically drink the iodine 131 agent, so it doesn't respond well to radioablation. The last subtype is anaplastic, which just sounds scary. This is the one that old people get. It's very aggressive, it's nasty, it has a terrible outcome. Now there's another subtype of follicular called the Hürthle cell. And this one is an uncommon variant. It's more aggressive. This type also does not take up 131 as well as a normal follicular does. And if you were approached with a next step question when following these up, the answer would be FDG PET. Okay, so things that don't do well with iodine 131 are medullary subtype, the Hürthle cell, which is a subtype of follicular, it's the mean follicular, and anaplastic. Cancers that have been previously treated, you can think about those as being battle tested. And anyone who's had methimazole treatment in the past, even if it was years ago, tends to have be more resistant to 131. So let's just talk about how thyroid cancer typically gets worked up. So family medicine palpates a nodule or just randomly end up with a thyroid ultrasound. Maybe you had an incidental nodule on CT. You see something that looks nasty. That gets a needle in it. Gets path comes back and it's positive. You go and you see the surgeon and they hack your thyroid out. The next thing that happens is that you want to know how much thyroid tissue is left. So you'll get a thyroid scan. Now, ideally you want uptake less than 5%. Uptake more than 5% if you go to do an ablation afterwards. So I should back up and just say the thyroid surgery is never 100%. It's impossible to get all the thyroid tissue out. And you also don't know if there's been micrometastasis hanging out in the body somewhere. So the standard is surgery followed by 131 treatment. But you don't just go straight to the 131 treatment. You stop here and you want to make sure that they got most of the thyroid out. So if there's more than 5% uptake left, then you go back to the OR and get cut up some more. Otherwise, if you try to ablate somebody that has more than 5%, it's going to really, 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 really hurt. And they may still try to do it. You'll probably need a bunch of steroids on top of the normal NSAIDs that they give to people, but a lot of times people will send them back to the OR. So before you treat them, you want to make sure that their TSH is really ramped up, because you want that residual thyroid tissue to be really thirsty. You want it to really want to drink that poison 131 up. You want to have a really, really good uptake of that toxic thyroid treatment. And the way to stop it, so what you do is you stop their replacement thyroid hormone. So normally they've had their thyroid cut out. They're going to be put on Synthroid. You stop that Synthroid, you stop that thyroid hormone post-op, and this makes them very hypothyroid, and it ramps up the TSH, and they hate that. It feels terrible. So once you get the TSH to a certain level, which is typically greater than 30, then it's okay to treat them. Now notice that when we talked about ablating Graves' disease or a toxic multinodular goiter, that we didn't talk about ramping the TSH up. That's because the TSH they already have hyperactive gland tissue, so that's not necessary. Whereas in this situation that you've got normal gland tissue that is going to require TSH. Okay, so how do you dose them? The dosage is based on how bad the disease is. It's based on the stage. So if it's local, right at the thyroid only, they get 100. If it includes some nodes, then they'll get 150. And then if they have distal disease, then they're going to get 200. Okay, so let's look at this guy. This is a whole body scan, and he has abnormal tracer. He's got abnormal tracer in a rib. He's got abnormal tracer in his chest and lymph nodes. So this guy is going to get 200. He's got everything. So what do you decide, or how do you decide whether or not this patient gets admitted to the hospital after treatment or if they can go home? So the NRC limit is 7 millirem per hour measured at 1 meter from the patient's chest. Some agreement states will use 5. Now remember, the agreement states are states that have decided that they're going to have more stringent guidelines compared to the national guidelines. They can never have less. So you can never go lighter than what the national recommendation is. You can go more strict. The number also to remember is 33 millicuries of residual activity. Some places will say 30 in strict setting. So those are your two numbers to remember as far as who gets put in the hospital. If they don't need admitted to the hospital, you have to give them a whole bunch of instructions. You have to tell them to drink a lot of water. This increases the renal excretion. You tell them to suck on hard candy. This flushes the tracer out of the salivary glands. Salivary gland damage is one of the possible side effects of 131 treatment, because it accumulates in your salivary glands also, and it's like burning them the whole time in there. So supposedly if you're sucking on sour candy or whatever, it'll flush that out. You have to tell them to maintain distance from people, distance principle, no riding in long car rides with another person, planes, trains, that kind of stuff. You have to sleep alone for 3 days. No kissing anybody, no sex with anybody. You have to have good, quote-unquote, good bathroom hygiene. Flush the toilet twice. Sit down. Even if you're a guy, pretend you're on the mammo rotation. You have to use disposable utensils, plates, clean your linen, etc. And most of this stuff is done for about 3 days. So the breastfeeding thing we touched on the first module. I'll bring it up again. If you get 131, your breastfeeding days are over, or at least this time around. And you're not supposed to be pregnant for between 6 months and 12 months after therapy. Little kids need thyroid hormone for brain development. Remember, there's this thing called cretinism, where hypothyroidism creates a retarded kid. You don't want that. will ruin your life. So it's very serious. No getting pregnant 6 months to 12 months after therapy. So what about pulmonary fibrosis? Is this a thing? Who gets that? Supposedly, if you have lung metastasis, and this is the macronodular disease, as opposed to micronodular disease, that's probably, let's not forget that I said that. Just lung mets equals fibrosis if you treat them. It's not necessarily a contraindication, but it is. You have to warn them that they're at increased risk for that. Sjogren's disease has an increased risk of salivary gland damage. This is why you tell them to suck on hard candies and stuff like that, but if they have Sjogren's especially, they're at increased risk. The absolute contraindications: pregnancy and uncontrolled toxic thyroid. These are your, because if you think about this, if you're already storming and you burn the thyroid and you spill the residual thyroid hormone, then that's just going to make it worse. So that's the way to remember that. Pregnancy should be obvious. There's this thing called thyroglobulin. This is a lab test that's used to monitor for recurrence. Anything over 0 after thyroidectomy is considered abnormal by the book. People with experience will tell you that the trend is more important, going up being bad. But anything that is above 0 is considered abnormal. So this is a normal negative 131 whole body scan. They always give the disclaimer and follow-ups to correlate with the patient's thyroglobulin level, because that is more sensitive than the test. If you have negative scans with an upward trend in thyroglobulin, a good next step could be PET. That sometimes will be something that people will go to. So here's the normal distribution in cartoon fashion. Thyroid, obviously, if you have one still. A lot of times you're doing these whole body scans in people who are post-thyroidectomy. Salivary glands, remember, because they burn your salivary glands. And bowel, because this is how you're excreting it. So what about this guy? This is a post-treatment scan, and you can see that he has uptake in the liver. So this is always seen post-treatment, and supposedly this is like a breakdown product or something like that. But if you see a thyroid scan with a hot liver, this is gamesmanship for telling you this is a post-treatment scan. So how do you tell if there are lung mets? So the trick is basically this. If you can see the heart shadow through, like it looks like an outline of the heart, you can actually make that out on the background of the lungs, then you have lung mets. Because you're dealing with micro metastasis, you're not going to see like blotchy, discrete mets a lot of times. It's just going to be, so they're not going to be focal. But if you can see the outline of the heart, then you have to call lung mets. So what about this guy here? This is the sinister 6, the level 6 lymph node, which some people refer to as a Delphian node. Supposedly, the Oracle of Delphia foretold various terrible events. By the book, buzzword, Delphian node equals laryngeal cancer. However, it can also be seen in thyroid cancer. And in this one, you would actually probably lead with thyroid cancer, and here's why. Notice that there are microcalcifications within these lymph nodes. This is classic papillary thyroid cancer. Papillary is popular, microcalcifications. This is a classic look for metastatic papillary thyroid cancer. So let's review the lymph node anatomy in the neck. So here are your submandibular glands. Don't forget those. Those are the balls of the mouth. They hang down the one on each side. The submandibular glands are the balls of the mouth. If you locate those first and you're at that level, you are dealing with level 1 lymph nodes here. A would be more medial to that. And then you could also be at level 2 when you are beyond the posterior border of the submandibular gland. So find the balls first. 1 is in front of the balls. Number 2 is behind the balls, which should be easy to remember because when you make a number 2, it comes from an area that is behind your balls. Sternocleidomastoid, 2A in front, 2B behind. So now we're down a cut, okay? We are underneath of the lower border of the hyoid, that thing. We're underneath of that, so we're at the level of thyroid cartilage. Again, here's your sternocleidomastoid. So level 3 in front, level 5A behind. So just a real quick refresher on anatomy. As you're descending down, hyoid's on top, then thyroid cartilage, then thyroid cartilage. You've got arytenoids that are at the very top of they're at the superior margin of the cricoid, bottom part of the thyroid cartilage. And then you've got your tracheal rings. So that's sort of as you're descending down, because it's unlikely that this kind of stuff would be shown on a scrolling situation. You have to try to level yourself up. So the lower border of the hyoid is going to be when you start having your level 3 nodes. And then below the cricoid is when you're going to start having your level 4 nodes. So here we are below the cricoid. We're no longer seeing that thyroid cartilage, which is the one in the middle. We still have sternocleidomastoid. So right square in the middle is your sinister 6. That's your Delphian node. 5B is lateral to the sternocleidomastoid, and 4 is behind it, or right at the same level of it. Okay, so that's the end. That's it for thyroid cancer, and the next lecture will be on the parathyroid. That's also a short one.